Good morning, everyone. So today's session, we will deal about your anatomical landmarks for your maxillary and mandibular completely edentulous patient. As we all know, so these are the anatomical landmarks for your edentulous jaw. This is for your maxillary arch. So when we say about your anatomical landmarks, we can classify them as a primary stress bearing area, which means the main stress that your complete dentures exist should fall only on these regions. And you have your secondary stress bearing area where along with this primary stress bearing area, the other stress can be transferred to the secondary stress bearing area, which can withstand certain amount of stresses as an helping to that of your primary stress bearing area. Next comes your relief areas and your limiting structures. So as such, the term itself determines the relief areas where the stresses shouldn't concentrate over the region, where the stresses should relieved completely from those regions. And you have your limiting structures, which will help us to determine or mark the limit of your extension of your complete denture. So when you see about the anatomical landmarks, you can see so you have your incisive papilla, palatine raphe, and fovea palatine, and your crest of your alveolar ridge. The things that are marked in green color constitute the relief areas, and your secondary stress bearing areas will be your rugae. Those things that are marked in pink, rugae, posterior palate, posterolateral slopes of your radial alveolar ridge, and your tuberosity forms your stress bearing area, and your things that are marked in blue color, your labial frenum, labial sulcus, buccal frenum, buccal sulcus in your vibrating line, and hamelar notch, those form your limiting structures of your complete denture. So why it is necessary to give relief for your incisive papilla, your mid-palatine raphe, and your fovea palatine? So incisive papilla will give away the nasopalatine vessels that come through the foramen that comes out from the incisive region. So if we give an excess pressure, what happens? It automatically give a pressure over the nasopalatine vessels that are coming out, which will ultimately result in numbness over the region where this nasopalatine vessels supply. So in order to avoid those things, it is generally kept as a relief area. And when you see about your palatine raphe, the mid-palatine suture, it is generally given as a relief area. Why? Because during the embryological stage, when both the palatine halves join together, they join at a level little bit higher than the adjacent region, which means the soft tissue that covers your mid-palatine raphe will be of very thin, and the amount of soft tissue which is seen above your palatine bone, mid-palatine bone, will be very thin. So when you give a denture, the forces that are created during your occlusion of your maxilla and your mandibular denture will transmit to the center of the denture. Ultimately, if more forces are transferred to the center of your denture towards the midline, where it is not supported beneath by good amount of soft tissue, the amount of forces that concentrate in the center will become more, which will ultimately result in breakage of denture, which will be such kind of denture breakage at the midline is classically seen in patients who are rehabilitated with a single complete denture kind, where the opposing forces from your natural teeth during occlusion and chewing will be more, which ultimately result in excess forces to be generated in the maxillary complete denture, and all the forces that are taken up by the denture in the teeth region will be transferred or will be directed towards the center of the denture, which will ultimately result in breakage of the denture in that region. So in that case, in case of a single complete denture, or in any other case, it is ideal to give a mesh in the fabrication of your single complete denture, which will help to prevent the breakage or any disturbance to the uh, single complete denture, or in case any other denture. So in that case, it is ideal to give relief for your palatine raphe. And fovea palatine, as we all know, it paves a way for the opening for various minor salivary glands that are located in the posterior soft palate region. The minor salivary glands that are minor salivary and accessory salivary glands that are seen in the posterior palate region will be will have its opening through the fovea palatine, and the location of fovea palatine is not consistent. It varies. In some patient, it will be seen in front of your posterior palatal seal region. In some patients, it will be seen behind. So it varies. And if it falls inside your PPS region, it is ideal to give relief in that region so it is not blocked. Because for your complete denture retention, as we have n number of factors, one main factor of retention that helps is your saliva. So if blocking by this, so the posterior salivary secretion will be hampered. So it is ideal not to give a blockage over your fovea palatine. So all this incisive papilla, palatine raphe, crest of alveolar ridge, fovea palatine are ideally kept as a relieving region. So for the same reason, like how your palatine raphe, the superficial soft tissue covering over your palatine, mid-palatine bone is very thin. Similarly, to the crest of your alveolar ridge. As such, your alveolar ridge is your main supporting area, main primary stress-bearing area, but the crest always will be a relief area in both your maxilla and your mandible. Because the crest, the soft tissue covering over the crest will be any day thin or very less in thickness. So it is ideal to get relieved those regions. Similarly, your labial frenum, your labial sulcus, buccal frenum and buccal sulcus, and your hamular notch and your vibrating line will determine the extent of your maxillary complete denture. So coming on to your mandibular complete denture anatomical landmarks, your limiting structure will be your labial frenum, labial sulcus, buccal frenum, buccal sulcus, and your retromolar pad will be your posterior extension of your mandibular complete denture, followed by alveolingual sulcus and your lingual frenum. So this is the extension. When you see about your primary stress-bearing area of your mandible, this is always your residual alveolar ridge and your buccal shelf area. And when we see about your relief regions, it will be your mental foramen, mylohyoid ridge region, genial tubercus, and if any torus is present in your lingual surface of your mandible, then those things can be considered as a relief areas. When we speak about the relief areas, mental foramen and all, I mean, not every cases you will go for a relief in those regions. Because your mental foramen is when we see anatomically, it is way below your sulcus, your buccal sulcus in those region. When it will come for a relief stage, where the amount of resorption of your mandibular arch, your mandibular residual alveolar ridge, if undergoes so much of resorption, eventually your sulcus will recede down at a more deeper way, during which your mental foramen will get exposed or will come to a clinical surface. In that region, in that case, it is ideal to relieve your mental foramen to avoid any nerve compression that pass out from your mental foramen. And similarly, in case of your resorbed regions, your junial tubercles, which give way for your genioglossus muscle attachment, should be relieved, which will result in imbalanced denture mainly in your lingual surface region. And again, your torus, as we know, torus, it is, if it is in the floor of the mouth, if it doesn't come in the limiting structures, it is always fine. If it comes in case of your limiting structure, if it comes in your lingual sulcus region, it is ideal to mark and relieve the tori completely in your denture extension, or else it will result in much painful process for such patient if it is included. So it is ideal to relieve your torus mandibularis. And as we all know, the main stress bearing area will be your buccal shelf area and residual alveolar ridge. So buccal shelf area, why it is mainly your stress bearing area? Because in your mandibular complete denture, if you see in your maxillary complete denture, your palate, your posterolateral slopes of hard palate will be a region which is like perpendicular to your occlusion plane, which means the occlusal forces will be perpendicular to that region. So the forces will get easily transmitted. Similarly, in your mandibular arch, only region which is not exactly perpendicular, but some way similar to it will be your buccal shelf area. So that is where your primary stress is concentrated. And one more reason, the bone that is present in your buccal shelf area is more of a cortical in nature. than just being cancerous. So it will easily take up the forces and dissipate very evenly. So when you see about your muscles that act over your dentures, there are like n number of muscles. So when you see your maxillary denture in the labial region itself, you have like 4 to 5 muscles action. So labially, the main muscle that act over will be your orbicularis oris. Then you have your labial frenum, which doesn't have actually any muscle attachment. Then comes your labia superioris on the either side of your labial frenum, and your levator angli oris will be seen next to your labia superioris muscle action. Then comes your buccal frenum, where your rhizorius will have action over that. Then in your buccal flange or your buccal curve of your maxillary denture will be the curvature of your buccal surface of your maxillary denture is mainly given by the action of your buccinator muscle. Then you have your distobuccal turn. So this is your distobuccal turn, which will be taken up by your coronoid process of your mandible. The coronoid process of your mandible will actually gives your distobuccal turn, or like how to record during your secondary impression when you're recording your distobuccal region with the help of your green stick or your putty. It is ideal to ask the patient to open his or her mouth widely and to move the mandible towards right and left. So the coronoid process of the mandible will give this proper curvature, or like it will limit how much your denture extension should happen. Then it is also determined by the temporalis tendon, which comes over this region, and your posterior segment of your mandibular denture will be recorded or will be limited with the help of your hamlar notch and your pterygomandibular raphe, which acts on the either side over this region. And the posterior in the PPS region is mainly influenced by your palatine aponeurosis, which is nothing but the action of 5 different muscles: your tensor palapalatinae, levator palapalatinae, palatopharyngeus, palatoglossus, and the uvula. So these are the different kinds of muscle action over your maxillary complete denture. When you see about your mandibular complete denture, similar kind of muscle action will be there, where in your labial region will be by your labial frenum, along with this action of your orbicularis oris along with mentalis muscle. Then you have your depressor angli oris on the either side of your mentalis muscle region. Then again the turn in your distobuccal along in the buccal region will be mainly because of your buccinator muscle, and the distobuccal turn in case of your mandibular complete denture is mainly by the action of masseter muscle. Then you have your retromolar pad region, which is mainly by a 4 different muscle action. First will be your temporalis, then your pterygomandibular raphe, then palatoglossus, and your superior constrictor muscle. So when they say about the muscle action in the retromolar pad region, it will be mainly by your 4 different types of muscles. Will be your superior constrictor, your palatoglossus, your pterygomandibular raphe, and your temporalis muscle. The alveolingual sulcus of your mandibular region will be mainly influenced by your mylohyoid muscles, and the regions where your genial tubercle will be seen in near your lingual frenum. So the action will be taken up by your genioglossus muscle. So there was a more of like confusions between like where is retromolar pad and where is your retromolar papilla. Both are same or both are different? Both are actually different. So retromolar papilla is nothing but a remnant papilla of your third molar, which is seen immediately next to the posterior distal most tooth in that region, and a pear-shaped pad that is more of non-keratinized, which is seen in behind your retromolar papilla will be your retromolar pad, and this region should be recorded during your mandibular secondary impression, which acts as a limiting structure, or which is your limiting structure of your posterior extension of your mandibular denture. It should be recorded. So one main catchy about this thing is the BTC point. It was in the year of like early 2000s. Dr. Jiro Abe. So he was a renowned prosthodontist. As we all you have come across a term called as like BPS dentures, suction effective mandibular complete dentures. So this was mainly a basis that was given by Dr. Jiro Abe of Japan, where he found a region called as a BTC point where near your retromolar pad region. So this is an intraoral picture to show the retromolar pad region. So this is your last teeth that was kept. So, and this region, this is the posterior region that is seen behind your last molar that was replaced. And this region where if the denture is not recorded in the retromolar pad region during closure, if it is not recorded, there will be a small triangular space which result in passage of the uh, underneath the air that was locked. So since there is an air leak in this region, so your denture will not get the proper seal. But when you see in your maxillary cases, most of the cases you will get a good amount of seal. But in your mandibular cases, you do how much ever bottom molding and try recording the extensions properly. If this region is not recorded, it will ultimately result in air leakage and your processes is not getting that proper peripheral seal. So in that case, it is ideal to record this region properly. And the importance for this region was given by Dr. Jiro Abe, and he termed this region as a BTC point, where he insists us in recording this retromolar pad region in a closed mouth condition. Generally, we'll extend this region with a green stick. We'll place your special tray with the green stick in the retromolar pad. We'll ask the patient to do the tongue movements and do all sorts of things, but we failed to ask the patient to keep his or her mouth closed during recording that region. So it is ideal to record those region with the patient's mouth closed, which will record this BTC point properly and which will help us to achieve the proper peripheral seal. So next important anatomy which was missed is your retromylohyoid curtain, where you have your mandibular foramen through which your inferior alveolar nerve passes through this. But in most common cases, under during different studies, you have a small foramen in your retromolar pad region or retromolar papilla region, which is seen next to your last distal most molar. A small foramen you can see here in all this radiographic studies and all this anatomic studies. You can see a small foramen which is around 5 mm ahead of your mandibular foramen that is seen. So what happens, one small string of nerve which enters through your inferior alveolar nerve will leave, once entering the foramen will leave, comes out through this retromolar foramen and gives a small innervation to the um, soft tissue or even to the teeth that is present very near to this region. So which is not regularly seen or not noticed in most of the cases, but now it has come to a limelight where even even this uh, will consider as a part of your mandibular edentulous region extensions, where this region should not given much compression. So these also should be taken care while doing your recording of your distal extension of your mandibular complete denture. Then one more thing which was very new, where it is termed as sinew string, which was brought to limelight around 7-8 years by Dr. Somia, where it was found in the retromolar papillar region, where behind the last molar there is a small white string-like structure that is seen, which is when we see with when we see without any pressure with the help of finger or mirror, it is not evident. But once we ask the patient to open his or her mouth wide, then pull the buccal mucosa in that region outside, there will be an elevation of a small string. So you can see this region. So which is also noted when we use your mouth mirror to retract the buccal mucosa or retract in the tongue region. You will small a white patchy string that is becoming elevated once it is under tension. Once we doesn't touch it, it goes back to its normal position. So this region is of much importance because during your masticatory movement, your buccal mucosa will undergo various movements, where during which when the food gets locked, when the food is located between the pouch where it is guarded on one side by buccal mucosa, another side by your buccal surface of your mandibular denture. Since the food getting lodging here, it will obviously will push your buccal mucosa outside, which ultimately results in development or elevation of this sinew string, which again will lift the denture without much force. So in that case, it is ideal to record or to be precise in recording in these regions so that you will give sufficient relief for this sinew string and also your retromolar foramen if both this relief is given, and we should be cautious enough to record this BTC point also. So when we see as such, the retromolar region is of very small, which is located beneath the behind the last molar. But to see there are like three different important structures are there. One is your BTC point, next is your retromolar foramen, and next is your sinew string. So all this recording and relieving of this region will help us to achieve a proper peripheral seal for your mandibular complete denture.